Okay, we're live. Let's get started. Welcome everybody at a new Bytes of Innovation webinar. Bytes of Innovation is a webinar that is powered by Segmed, a company that provides real-world imaging data to researchers, mostly for AI developers, but also for real-world evidence applications. At Bytes of Innovation, we invite key opinion leaders to talk about the future of healthcare. And this show is co-hosted by Dr. Ali Lutz, who is the VP of Real-World Evidence and Clinical Insights at Segmed, and by myself. My name is Martin Willemink. I'm co-founder and Chief Scientific Officer at Segmed. So all people in the audience, make sure to put your questions in the chat box so that after the presentation of today's speaker, we can discuss those questions. And today, I am proud to announce that we have Dr. Martina Aineseder amongst us. She is a body radiologist specialized in gynecologic imaging. She works at the Hospital Italiano de Buenos Aires in Argentina, and there she serves as the head radiologist of the institution's AI in Healthcare program. That means there that she leads the clinical development, the validation and the implementation of AI solutions in real-world practice. She's also currently a master's candidate in health informatics with a focus on integration of AI into clinical workflows. Martina is a very busy person because she's also secretary of the AI chapter of the Argentine Society of Radiology. And very importantly, she also works as a consultant radiologist at Segmed. Today, Martina is going to give a presentation on how to build an AI team inside a health center. She will share her experience in a Latin American hospital. Martina, the floor is yours.
Thank you, Martin, for the introduction and for the invitation. It's a pleasure to be here. So I will share my screen. Do you see my screen?
Yes, we
Yes.
see. There we go.
Perfect. Perfect. So when we started exploring the implementation of AI in clinical practice, we first assessed the capabilities we already have as an institution. As a large academic hospital, we have strong digital infrastructure, including an integrated PACS, electronic health records, and technical teams, which gave us a solid starting point. However, we identified several key gaps that needed to be addressed before safely implementing these technologies. A validation gap, since most algorithms had not been tested in population like ours, a regulatory gap due to limited clarity around local frameworks, a governance gap with no clear internal structure to oversee the system, and an integration gap because many tools were not designed to fit seamlessly into our PACS workflow. So to better explain the context, I will briefly go through each of these points in a bit more detail. So I work at Hospital Italiano Buenos Aires, which is a non-profit, high complexity and academic hospital. An important characteristic that distinguishes the hospital is being a technological pioneer in our region. In multiple fields, from robotic surgery to digital health, the hospital has always been a pathfinder and an innovator. Here's a little historical context. A long pathway in the adoption of digital health technologies has key to prepare an adequate scenario for AI to appear. For over 20 years now, the hospital has had a health and informatics department with more than 200 employees, having developed all its health information system in-house, including its own electronic health record and reporting system. This setting encouraged that as AI started to raise attention in the scientific community, the health informatics department and the radiology department decided to co-found an AI in health program inside the hospital. After a year, the first AI system developed by the hospital was implemented in clinical practice for automatic assessment for breast density. One point that I would like to emphasize here is that the different gaps I will go through in the next slides needs to be understood in the context of 2019, which is when the decision was made to create the AI team. One of the first challenges we identified was the validation gap. Most AI algorithms available at that time have been developed and trained using datasets from North America and Europe. As a result, Latin American populations were largely underrepresented in the data used to build and test these models. This is important because, as you know, algorithmic performance is strongly influenced by the data it learns from. In our region, we might see differences in disease prevalence, variations in the stage at which a disease is diagnosed, and also variability in imaging protocols and equipments across institutions. All of these factors can influence how an algorithm behaves in real world clinical practice. Another important challenge at that time was the regulatory landscape. Many of the AI tools available at that time had regulatory approval in the United States or in Europe. However, there was no clear regulatory pathway for these technologies in our territory. This created uncertainty for institutions that were considering clinical implementation. Because of this lack of a clear defined framework, adoption was not only a technical decision, but also an institution and legal consideration. Another important gap we identified was the lack of local technical governance. At that time, there was no internal structure within the institution dedicated to overseeing the behavior of AI systems once they were deployed. This means that if an issue arose, for example, an unexpected result or performance concerns, the only option was to escalate the problem to the vendor. In many cases, this meant contacting teams located abroad, since there were no local company representatives at that time, only resellers distributing the products in the region. As a result, there was no immediately technical support capable of analyzing how the algorithm was behaving with our specific legal environment. We also had very limited ability to audit, monitor, or contextualize the performance of these tools using our own data and workflows. The final challenge we identified was the integration gap. Many of the AI tools available at that time not fully integrated into PACS or environment or reporting workflow. In practice, they often meant working with different interfaces in parallel, additional platforms, or separate logins in order to access the AI results. Even if the algorithm itself performed well, this type of workflow friction significantly reduced usability. And as you probably know, in radiology, workflow integration is critical. If a tool requires additional steps or disrupts the reading process, adoption among radiologists becomes very limited. Based off these challenges, the hospital decided to create an internal AI program. Our team within this program can be summarized through three key characteristics. First, it is a transdisciplinary team. It brings together professionals from multiple fields, including physicians from different specialties, statisticians, software engineers, data scientists, and AI engineers. But beyond simply having different profiles, an important aspect of this team is that we are able to communicate effectively across disciplines. Second, the program has a translational focus. Our main goal is not only to conduct research, but to develop projects that can truly impact in the clinical workflows. We focus on solutions that can move from development to real-world implementation and can be used in everyday clinical practice. And finally, we are also a training program. We dedicate significant effort to educating young professionals through internal courses, workshops, and most importantly, by providing opportunities to learn through hands-on experience and real projects. So, as you probably know, the great gap between the innovation lab or the research scenario and the real clinical, there is a very gap in these 2 points, the real world and the innovation lab. So we believe that the main question that we would like to answer for this the presentation is how to carry out AI projects in health that successfully jumped from research studies to real world. This translational job is the main challenge when developing AI systems. So our story of these years has included, of course, both successes and failures, learning from mistakes until finding an adequate way. And we believe that there are too many main outputs that we build after this process. First is a standardized operating procedure for conducting AI health projects inside a health center. And secondly, a teamwork methodology that is both transdisciplinary and agile. We have worked hard in the standardization of the steps involved in developing and integrating AI tool in the healthcare to develop a reproducible procedure so as to guarantee that the important aspects are considered at the right time and that all the key tasks are performed throughout the process. By this, I mean like don't make the same mistake twice. This is a summary of the steps that we use to plan and carry out our projects. The first step is the feasibility analysis. It is an evaluation performed before starting any projects that we survey the needs of the user and understand the problematic by analyzing like the target clinical processes, the literature, and the available data to decide useful objectives that can have an impact in patient care. So here we answer questions like what image study will we use? It is a usual procedure, or how will AI improve workflow? Who will benefit of the result? Can it actually assist in decision making? What would be expected use for screening and for diagnosis confirmation? And what are the costs of omission? And what would be the consequence of false detections? Here, I present as the example of three common types of clinical impact among our projects. Firstly, an AI tool that can be used to transfer knowledge of one specialty to another. In the case of the system that analyze emergency chest X-rays, the main target users are the emergency physicians or general practitioners rather than the radiologists, as these studies are not usually reported immediately by a radiologist. So the AI results serve as a double reading for the non-specialist who must perform his or her own interpretation of the image. Another example is the detection of potentially unstable spine metastasis. There is a validated scoring to evaluate the spine stability. This score is well known among spine surgeons, but radiologists or oncologists are not familiar with it. So this causes that patients who should have a spine surgery before starting other oncological treatments are often referred to the spine surgeon with a great delay. This AI tool for automated quantification of vertebral metastasis instability is not aimed at the spine surgeon. Its objective is alerting radiologists or oncologists on the urgency for referral to a spine surgeon. A useful role of AI that is aimed at radiologists is reducing inter-observer variability at the time for report writing, which is the case of automatic breast density calculation or bone age calculation. Besides, depending on the application, the results can be useful for the physician who ordered the study as an immediate preliminary result. Finally, some tools will help to organize the radiology work list, giving priority to studies where AI detects critical findings. An example is our tool for detection of findings in brain CTs in emergency settings, which is currently being developed. The feasibility of a project depends largely on the availability of useful imaging datasets. There are two main sources for us, at least, for data that are open datasets or local hospital datasets. In most of the cases, we use our data. So in that case, we have to determine the size of the dataset and know who will be collecting the images of interest. Many times, a manual revision is needed to find the studies that meet the inclusion criteria. And regarding the annotation procedure, we ask questions like, could we obtain automatic labels from reports, or should specialists review the images? Will be provide that image class or localized with a bounding box or perform a volumetric segmentation? Other question that we have many times is our target variable has a strong inter-observer variability. We have to know that we have to consider building the true label as a majority vote across the multiple professionals, because always remember that the AI model can only be as good as the data we train it with. All of these aspects determine the time and resources that we will have to invest in building datasets. In case that the project is feasible, we prepare a project charter and a study protocol that is presented to the institutional review board for approval. And only then we start to develop the AI model. In this stage, medical specialists and engineers work together to collect images and run through labels and process the data. Here, AI engineers design and train a variety of algorithms and try and test fashion to find the most optimal architecture. Using the latest frameworks for computer vision and algorithm development, the AI engineer works. Another key to consider here is the availability of GPU processing and units needed to train the deep learning models. The performance analysis always take into account that the targeted clinical use and health professionals are constantly keeping the loop to evaluate preliminary results in light of their own clinical insights. When an optimal performance is reached, a strong validation is performed. So we call this step the proof of concept. The proof of concept consists of designing a study protocol to measure the performance of the AI model in a scenario closer to the real world. It is crucial to work with a sample of local studies and to use reference standard that represents the intended use of the system with target users as participants. This also strengthens their engagement as future users. Here's an example of a proof of concept that we did with our bone age calculator that is called Carpian, in which we compare the results between different observers, that in this case were radiologists and pediatricians with different levels of expertise. The AI model is only a small part of the entire software applications we need to integrate the tool with other information systems. If the proof of concept has successful result, we develop software components to communicate with PACS, with the electronic health record and the radiology information system, and of course with other systems too. This interoperability is crucial, and it inserts the AI result into the daily work of practitioner in a natural, simple, and a user-friendly way. We perform usability tests too. But by this, I mean user-centered design and training of the professionals who will be in touch with the AI tool. In the beginning, the new system is deployed only for a reduced group of users. This pilot stage allows us to refine functionalities and correct technical difficulties that only appears once the system works in a real productive setting. A very important tool for us is the management dashboard. This dashboard is a tool whose objective is to properly diagnose a situation through daily monitoring. It allows us to know the current scenario in order to propose a relevant action strategy. This is an example of one of the management dashboards that we have for one of our projects that is currently implemented in the hospital, which is a tool for automatic detection of findings in chest X-rays. Just by looking at the dashboard, we can know how many X-rays the tool detects with findings, which users are using the tool, as well as the usage rate, which give us a status of the tool usage and allows us to generate actions in case the usage drops significantly. The next step is implementation of the AI system. Here's when we evaluate the impact of the tool in production and user satisfaction. For all our implemented AI systems, there is a survey in which, through a Likert scale, the user, in this case a radiologist or a non-radiologist physician, can express how useful he or she found the tool. Our user experience evaluation is based on evaluating two types of sources: quantitative sources, in which we measure with the feedback from the users with the surveys that I showed you in the previous slide, and with validated surveys sent by email to the users, such as the usability case system, and qualitative sources for which we interview professionals who use the tools. The output quality of the tools is usually evaluated through feedback from the radiologists on each study they analyze. Through this feedback, they tell us if they agree with the interpretation of the AI system, or there is a disagreement error, by this I mean a false positive, or there is an omission in the finding, by this I mean a false negative. And here another example of the results we obtained from the feedback of, in this case, non-radiologist physicians users through a Likert scale on the usefulness of the tool. An important point is the continuous improvements for us of our developments to optimize the work, the quality, and the performance of the processes. And just to conclude, one of the key lessons from our experience is to value of having an in-house AI in-house team within the healthcare institution are, first, that it allows us to strong end user engagement. The professionals who will ultimately use their tools are involved early in the process, which helps ensure that solutions truly respond to our needs. Second, it enables system governance. Having internal expertise allows us to monitor, evaluate, oversee AI system locally, ensuring that they behave as expected within our clinical environment. And third, it represents a long-term investment for us. Building internal capacity allows the institution to progressively develop knowledge, expertise, and sustainable innovation. At the same time, our strategy today is increasingly hybrid. In recent years, we have also incorporated commercial AI solutions, particularly as the ecosystem in our region has matured. However, these tools are only adopted after a structured evaluation process that includes local validation, security, and IT assessment, budget analysis, and a careful evaluation of the intended clinical use and workflow integration. In this way, our internal AI team allows to combine institutional capability with external innovation, adopting new technologies in a responsible and sustainable way. I think that's all. Thank you so much.
Thank you so much, Martina. Great presentation. It looks like you had a lot of challenges throughout the way. And I would say it's probably kind of naive to look only at the algorithm performance and not think more holistically how to tackle all these challenges and in implementation and how to monitor the algorithms over time. And it seems like you are tackling all of that. So my first question is, when you started building the AI program to now, what turned out to be harder than expected? And on the flip side, what turned out to be kind of easier than anticipated?
Yes, thank you again for your question. One of the biggest challenges for us was realizing that AI in healthcare is much less about the model itself and much more about the ecosystem around it. By this, I mean data access, data quality, regulation concerns, IT integration, clinical workflow alignment, and much more time than that people or us initially expect. And another challenge was cultural, because clinicians, engineers, and data scientists often approach problems very differently. Building a shared language and common goals between those groups took time, but it was essential, important for the program to work. And I think something easy, it's hard to think about it. At first, the data set, to build the data sets inside the hospital was very hard. But when we established a process, it was very easy for us to collect the images. I think that could be one point. Another point that made things so much more easier was to have a very clear workflow and a very good feasibility analysis at first, because when we started with the program, we used to accept all the projects, and then we saw that it was no point. We had enough the resources to accept all, and not all the projects, as good as they look at the first, had like a clinical impact in our daily practice. So yes, it was like quite a process.
And what were your impressions on the clinicians, the early adopters versus the skepticals? For instance, in the surveys, you showed that a high rate of clinicians, of radiologists, were actually satisfied with the tools. But I'm wondering, did all of them answer the survey? How did you see the collaboration among your peers?
Yes, doing the user satisfaction studies were both very hard. With radiologists, we have like very good acceptance. I think radiologists are early adopters of technology. But you can see that with Bytes, and we have history with adoption of technology. So we don't have many issues in the radiology department. The issue was outside the radiology department because we had a lot of more clinicians that were using this tool, specifically with the chest X-ray tool. So we had to do many pieces of information to share what was this AI tool, how it works, what about the false positive, the negatives. So it takes a lot of time, but giving information, it helps us to add that the clinicians adopt these tools.
Got it. I guess it makes sense that with the radiologist also you have a much better, like shorter communication lines because you're a radiologist yourself, and then you have to communicate with non-radiologists, and getting them on board is much harder. Okay, so what you described here, what you presented is really amazing. Like you have a lot of resources, it sounds like, and a big team and working with a lot of people on this. Not every hospital, of course, has these capabilities. But what do you think when you look at the different team members in your team here? What are the kind of expertises that are necessary, and like how many people are needed, and what kind of backgrounds do those people have?
Yes, I don't know. I don't think that you need a huge team at the beginning. You need the right mix of profiles. First, clinicians or radiologists or physicians, that people who understand the real clinical problem and can define meaningful use cases. Then data scientists or ML engineers that can actually build and evaluate the models. And third, IT and data infrastructure experts, because accessing imaging data, integrating with PACS or the EHR, and ensuring security is critical. And finally, see that it was very important for our team is someone who can coordinate the program strategically, bridging clinical, technical, and institution priorities. So I think that I don't know if it's about the numbers, but to start with, I think it's important to start with a small team, but with this right mix of professionals.
Got it. Yeah, that seems pretty advanced, and but great that you have the capability or the access to those kind of resources. I guess my next question is a little bit in line with that, as in you mentioned all the problems, especially a few years ago when you started. Like there weren't many tools available that were tested or trained on data sets from your geographic region. I guess non-academic hospitals that don't have the resources that you guys have probably have similar issues. What do you think they should do? Should they also come up with their own AI team and do their own homegrown method developing, or should they collaborate with you, or what do you think they should do?
I think first of all, it depends on the hospital. Here in Argentina, we have like a very big gap between hospitals. So the first thing I will ask them is why do you want to start an inside AI team, and if you have the resources to build an AI team, and if they that two questions are answered. I think the optimal scenario is like an hybrid ecosystem that we have now. Hospital, I think, should not try to build everything themselves. Industry can develop highly scalable solutions and invest heavily in engineering and product development. But I think that hospitals need internal expertise to evaluate, validate, and implement these tools responsibly. In our case, as I mentioned, we started with internal development to build expertise, but in recent years, we also adopted several commercial solutions, as always, after a careful validation and alignment with our clinical needs.
Mm-hmm. Yeah, okay. And then one thing you mentioned is the integration of these AI models in the clinical workflow, right? Like integration typically in PACS systems, since we're talking about radiology here. How do you right now take care of the integration in the PACS system? Are you collaborating with like PACS vendors to get that done, or is it all internally done? And then yeah, and then a follow-up question on, have you looked into the AI deployment platforms that are commercial, that maybe you can develop your own AI model, but use like a commercial deployment platform that has already an integration with the PACS system?
Yes, I will ask first the second question, and I go to the first. Yes, we explored that possibility, but it was something that the hospital didn't want to do because they are very careful with security, IT security. So they discard this option. Nowadays, with the commercial solutions, we are almost integrated. There are some points that they are not fully integrated with, but we work very hard to try to integrate everything in one window, to the radiologist can read the study and see all the results and compare and then write the report. So we are working a lot with the integration, but because as I mentioned, I think it's crucial, because if you have to open, I don't know, 3 windows to read and study, you won't use that tool. So we are working a lot on that, and we're trying to day by day fully integrate these commercial solutions in our packs.
Got it. And then, so I understand you want to develop your AI models, like it's cool and everything, but actually, and you mentioned that you also do the feasibility analysis, but how do you actually evaluate the clinical impact? Are you looking at area under the curves of the performance or the accuracy of the model, or are you looking at actual financial or economic returns and benefits? How are you actually evaluating this?
Yes, we do both. First of all, we usually with the commercial solutions we have like a demo for I think the mean is like 3 months, and in that 3 months we see first of all how is this tool performing. It can be the area under the curve or different metrics. It depends on the type of finding that we are testing. And in parallel to, we do some budget considerations, and we see if this product that we are buying, we have a return in our investment or not. So we do both tests.
Super interesting. So Martina, I'm curious, along with this way of balancing commercial tools versus in-house developments, what do you think drives most of your development? Since you are in an academic hospital, would you say it is more kind of clinical need or patient care improvement, or it is more motivated by novelty, academic curiosity, and it's probably both. But I'm curious, how do you balance projects? But because there are many options, many paths you can take in development.
Yes. When we first start with this program, we used to have like one leg was for only research, and the other leg was for projects that we know that they could be implemented in the real clinical practice. Nowadays, because we don't have many resources for do both things, we try to select projects that could really have an impact in real clinical practice. I don't know, we used to do some research in radiomics, and we see that it all was all from research, and we couldn't implement that in the real clinical practice. So we started to accept only projects that will, I don't know, as you say, improve the patient care or reduce time with the radiologist or reduce errors, but that could be implemented in our environment.
Yeah, makes sense. And what about economic evaluation or return on investment of either the program in general or for a specific project? Have you done that?
Yeah, we do that with the commercial solutions that we want to buy, because there's like a discussion if the patient has to pay extra for the AI solution if they want to that their study wants to be with the processed by AI tool. For the internal process or internal projects, we don't do an return of investment study. We could do that. It's true that we could do that, but we don't have many resources to do all the tests. So we prefer to do that with the commercial solutions, that we have to uh, tell why we have to acquire that product to the hospital rather than the internal products. That's the truth.
And what about funding? Where does the funding come from mostly?
It's for the program. It's internal funding from the hospital, the informatics health department, and the radiology department. This is internal.
Yeah. So I think funding, since we are talking about Latin America initiatives, it's always important to disclose. I think it's great to have intramural funding, but for those that do not, we should always be looking for options so we can start our own programs and implementing programs elsewhere. Martin, do you have other questions?
Yeah, definitely.
I want to say something about that.
Yeah.
So sorry, Martin. I mean that yes, we used to look for grants, but one thing that maybe here in Latin America is different from the US as that the grants here don't have the same budget as the US, that you can do a lot of things. So we've won many grants around these years, but the budget is very, very small compared with a grant in an academic hospital in the US. So that's another point to mention too.
Yeah, money and resources is always the most difficult component here, of course. So, yeah, and getting extramural funding is very, very hard. Intramural funding is hard as well because you got to have the money, but it's both very hard. Martina, you showed one graph, like the timeline graph, where you showed, okay, 2019 was when you implemented the first AI model clinically. And then you listed, I think it was five models. How many models have you to date with your in-house program implemented, and which one do you think has had the most impact on the clinical workflow?
We have 4 models that are implemented, and I think the one that made the difference was the chest X-ray tool for findings, because in the hospital the X-rays are not usually read by the radiologist, because there are a lot of X-rays and there are not enough radiologists to read the X-rays. So many times in the emergency room, it's the non-radiologist, the clinician, that has to look at the X-ray. So it has helped a lot. We made a lot of tests to see if this tool was really helping this physician, and we saw that the tool is not performing as a radiologist, but it performs better than a non-radiologist physician. So we have another point for this X-ray tool that is for pneumothoraxes. For us, it's a critical finding. It's a find that you have to call the doctor of the patient to tell, okay, this patient has a pneumothorax. So we have an internal flow that with the AI system detects an pneumothorax, it automatically call the radiologist which is on call, who is on call, and the radiologist see the X-ray, and if the AI was correct, he or she immediately calls the physician to make sure that he or she knows that his or her patient has a pneumothorax. So I think that was the tool that made the difference in our hospital.
Got it. That's very cool. We're almost at the end of the webinar. I wanted to ask one more forward-looking question, maybe, and that is, we just came back from ECR and heard a lot about these newer broad-based general foundation models. So historically, we've had all these narrow AI models that can do one task, for example, pneumothorax detection. These newer models can actually tackle multiple features or multiple things at the same time, but they require a lot more data and more technical capabilities in compute, for example. Is this something that your team is also thinking about? Like, hey, maybe we can switch gears and ramp up and start developing these more complex models, or are you still sticking to this specific clinical problems you want to tackle and just keep doing what you're doing now?
In the case of chest X-rays, the tool detects not only pneumothorax, it detects nodules or opacities, fractures, pleural effusions, and it measures if the heart is big or not. So it detects, I think, the most important findings for a chest X-ray. I think that for this newer solutions, I think we are preferring to uh, see commercial solutions, because I think they're more scalable than us doing all the work. So we are, as I mentioned, now it's like a hybrid team. So we're preferring to take a look at the commercial solutions.
Yeah, that totally makes sense. You can just pick and choose between what's commercially available, what can you develop yourself, what's realistic, and what can you focus on.
Yeah.
Okay, makes a lot of sense. Well, I want to say thank you, Martina. This was a very interesting presentation, and thank you for your contributions. I guess my take-home message is it is possible for hospitals to develop their own AI models and to actually apply it clinically. But I think another message is it's still not easy. So Martina, thank you very much. I also would like to thank my co-moderator Aline, and of course Andrea, who has been doing a lot of work behind the scenes, and the audience for attending. Thank you all for being here. The next Bytes of Innovation webinar will be on Tuesday, April 14th, with Dr. George Harston, who is the Chief Medical and Innovation Officer at Brainomics. So I hope to see you all then, and thanks again, Martina.